afternoon. We are the group presenting on headaches and epilepsy. My name is Rutindo Munyati, and I'll be presenting with my colleagues Hafsa Abu and Didi Tsitsi. So we focus the content of our presentation based on what we commonly see in the primary healthcare setting. So first, we're going to be presenting on headaches. This next slide. Okay, so headaches is one of the most common complaints that we come across in the clinics. When seeing a patient who presents to your consultation room with a headache, the history is very important in guiding you towards what the possible etiology is and what subsequent systemic examinations may be required. These are some of the important points we put down that you must take note of during your history taking. So the first one is, what is the patient's age? Often we're more concerned at the extremes of age, so above 50 and younger children who present with headaches. Secondly, what is the site of the headache? Does the pain radiate anywhere? Asking the patient to show you where the headache is can often give you an idea of the cause. Tension often being bilateral in a typical headband distribution, whereas migraine often presents in a more unilateral distribution. It's also important to note if the patient has any comorbids. Illnesses such as HIV, cancer, or uncontrolled hypertension would make you more concerned for possible secondary cause. The onset and duration of the headache must also be noted. You must determine if the headache appeared suddenly or was it of a more gradual onset, and how long has the headache been there for, hours versus days versus a headache that has been reoccurring over a prolonged period of time. The character and severity of the headache can also give you information on what the possible cause is. So a dull aching headache will likely lead you down a primary headache route, whereas a severe thunderclap headache, as we all know, is usually associated with a serious diagnosis such as subarachnoid hemorrhage. Any other associated symptoms must be noted. Migraines can often present with nausea and vomiting, and also visual, motor, or sensory auras. In addition, other symptoms can reveal possible secondary causes of a headache, such as sinusitis, dental issues, or any eye complaints. And then lastly, precipitating events such as trauma must also be ruled out. So on your examination, the examination will be guided by your history taking, but in general, when you look at your vitals, it's important to take note of the patient's temperature if you're suspecting a possible infective cause. In addition, the blood pressure, respiratory rate, and heart rate could reveal potential secondary causes of headache. For example, an uncontrolled hypertensive or a Cushing's response in raised intracranial pressure. On your general examination, a patient who looks chronically ill and unwell will lead you to suspecting a secondary cause, whereas a generally well person would make a primary cause more likely. So because of time constraints in the clinic, it doesn't always allow for us to do a full neurological examination, but it's important to take note of the patient GCS, if there's any meningism present, and if there's any focal neurology. Depending on your history, a more detailed neurological, ENT, or opthal examination might be required. So this is just a useful mnemonic, which can be used to assist you in remembering some red flags for secondary causes of headaches. The S is for systemic symptoms, such as fever or weight loss, and also stands for secondary risk factors, such as HIV, cancer, or any other comorbid. The N stands for neurological symptoms or abnormal signs. The O stands for onset new and older than 50. The second O stands for onset abrupt. So for example, thunderclap headache. And the P stands for papilledema, positional, and progressive headache. So your bloods are going to be directed by your clinical examination, but most patients don't need further investigations. And those that do will likely need to be referred from the clinic setting. If the patient looks chronically ill and just suspecting immune compromise, BCT can easily be done within the clinic. So once you've ruled out your red flags and there's no identifiable secondary causes, the patient is diagnosed with a primary headache, which means the headache is due to the headache condition itself and not another cause. The two most common causes that we come across are tension type headache and migraine headaches. So tension type is typically in a bilateral distribution, often described as band distribution. It can last for hours to days, and it's not usually associated with other symptoms. Whereas migraine is often unilateral, but can also present bilaterally. It's often described as pulsating. Duration is typically 4 to 72 hours and is often associated with nausea and vomiting, and auras, which can be visual, motor, or sensory. Another type of primary headache we just put here is a cluster headache. It's less common and often presents with unilateral eye pain. The headaches are normally quick onset and associated with lacrimation, rhinorrhea, forehead sweating, and also Horner syndrome of the associated side.
So once we've referred our severe cases, i.e. our cases with the red flags, how do we then manage the following common causes? So the main set of treatment for both tension and migraine headaches are simple analgesics such as NSAIDs and paracetamol. For migraines, triptans have been found to be very beneficial, but aren't readily available in our primary health care settings. Symptoms like nausea and vomiting can be treated with metoclopramide. If these headaches are debilitating, if they're frequent, or if they fail relief with the simple analgesics, then the patient may require prophylaxis. For both tension and migraine headaches, low-dose tricyclics such as amitriptyline may offer some benefit, in addition to non-pharmacological management, such as cognitive behavioral therapy, which may also be explored. Although not so common, for cluster headaches, oxygen therapy, often in an ED setting, seems to mitigate symptoms, as well as a short course of steroids. It's also suggested that prophylaxis be given with verapamil. So before initiating treatment and with every chronic headache patient, it's really important to evaluate for headache triggers, as well as analgesia overuse headaches. Potential triggers include diet, stress, sleep pattern, sensory stimuli, and medications. Counseling on avoiding these triggers also forms part of the treatment plan. So the next part of this is epilepsy, which is another common condition that's often found in primary health care. The International League Against Epilepsy defines epilepsy as two unprovoked seizures more than 24 hours apart, or the diagnosis of an epilepsy syndrome. Seizures can be classified into three different categories. Those of focal onset, those of generalized onset, and those whose onset is unknown. Importantly, for seizures, one needs to know how to recognize a seizure. This we do by describing its characteristics. So for a generalized onset seizure, the onset is often abrupt, lasts less than 5 minutes, includes a loss of awareness, and results in tonic-clonic movement, often with tongue biting, incontinence, post-ictal confusion, with or without weakness. For focal onset seizures, the onset may also be abrupt, but may be either visual or sensory or motor, depending on its anatomic location within the brain, often has a typical anatomic march, and this may be with or without a loss of awareness. It's also important to keep in mind that there are other things that can mimic a seizure. And to differentiate between these, it's very important to take a thorough history. If the description of the event does not match the characteristics of a seizure as described before, one must then consider the mimics, which include the following: psychogenic non-epileptic seizures, syncope, transient ischemic attacks, migraines with auras, as well as movement disorders. Essentially, any acute insult to the brain can cause a seizure, which by definition would be a provoking factor and exclude the diagnosis of epilepsy. But based on your clinical picture, you need to consider other causes of your seizures, grouped broadly into the categories below: vascular, infective, ischemic, traumatic, pregnancy-related, toxic metabolic, as well as acute medical illnesses. The majority of the causes of epilepsy are of unknown etiology. However, the other causes include genetic, structural, metabolic, as well as immune causes.
So before diagnosis be excluded, electrolytes and metabolic abnormalities, eclampsia, hypoglycemia, HIV, syphilis, and encephalopathy from a general medical illness. Once the diagnosis of epilepsy has been made, the following workup is appropriate. A baseline CT brain is recommended, but we often neglect it in the clinic setting due to limited resources. An EEG also forms part of the workup. However, it does not rule out epilepsy. It does not rule out epilepsy if it is negative. But epileptiform abnormalities are present, it can strengthen the diagnosis. So currently, there is no uniform definition for control in epilepsy. However, in the consulting room, our goal is to assess the following: adherence, seizure frequency, triggers, medication side effects, and the impact of seizures on daily living. It's also always important to ask about family planning in women of childbearing age. And despite there not being a definition for control, the goal of treatment is to achieve a seizure-free period for at least 2 years. So if a patient reports having seizures in the consulting room, it's important to ask about triggers. And these are some of the triggers that one would ask about. You could ask about sleep, alcohol use, drugs and drug interactions, excessive audiovisual stimulation, depressives or stresses, and non-adherence to treatment. While in the consultation, one should also screen for the following side effects. Urgent intervention are rash and jaundice. A rash is an indication of a hypersensitivity reaction and requires immediate referral and stopping of the drug. Jaundice is also a concern as it can indicate hepatotoxicity. Other non-life-threatening side effects are shown here, and for these, we should assess patient tolerance and manage accordingly. So here we have shown some of the treatment options for epilepsy. The aim is to use monotherapy and to progressively increase the dose until seizures are controlled and there are no side effects. So we can use Epilim, which we start at 300 weeks, to a maintenance dose of 500 to 1,000 milligrams BD with a maximum dose of 1 gram BD. We can also use carbamazepine at a starting dose of 100 milligrams BD and increase by 100 to 200 milligrams weekly to reach a maintenance of 300 to 600 milligrams BD with a maximum of 600 milligrams BD. We can also use lamotrigine, 25 milligrams daily, and increase it by 25 milligrams weekly. If the patient is already on Epilim, we start with 25 milligrams on alternating days with a maximum dose of 250 milligrams BD. So we can monitor the success of treatment with the use of the seizure diary. But therapeutic drug monitoring is not routinely done unless you are confirming toxicity in a patient who is symptomatic, a patient with poor control, and to confirm subtherapeutic drug levels despite self-reported adherence. Breakthrough seizures happen when a previously seizure-free patient presents with seizures. This warrants investigation as to the cause, which includes electrolyte and metabolic abnormalities, non-adherence, intercurrent illnesses, medication interactions, ethanol use, and other triggers as stated previously. Most patients can be safely discharged back to the clinic once the cause has been established and corrected. So here we have a short note on status epilepticus, which is a common medical emergency that will present in the ED. It is important to familiarize oneself with the guidelines for treatment of this condition, which we have placed on the slide from EM guidance. As with any medical emergency, we check the ABCs and look for correctables, which include glucose and electrolytes. We also place the patient in the left lateral position, and treatment is stepwise with the aim to abort the seizure using a benzodiazepine and to load the patient with an anticonvulsant. The anticonvulsant chosen here is phenytoin, but Epilim and phenobarbital can also be used. And that's all on epilepsy.